This update, which I'm going to give you before lunch here, feeds in very nicely with what you've just heard from Jean-Luc about the relationship between the depth of the response and the ability to have long remissions and to maybe even to start to be able to cure myeloma. And so this is the basis of this Black Swan research initiative. And so the project involves an underlying theme, but it has multiple smaller projects within it. Right now, in fact, it has 5 sub-projects, and so that's why right here in the ocean we have the big swan and then some 5 little swans floating over here. It's spawned a number of sub-projects to investigate various aspects of this approach to the treatment of myeloma with the intent to try to find a treatment that can cure myeloma. So these are the bullet points. These are the basic elements of what this project is all about. And this came from a meeting that occurred almost 3 years ago now to try to think about what would be the way to come up with a cure for myeloma. And so the first idea from this team was that we have to be able to measure myeloma at a very, very low level to be able to figure out what we're doing. If you can't track the disease at a low level, then you actually cannot develop a better therapy because you can't understand what you're doing. And so if you have a complete remission and it's below the level of detection, then it's no good. You need to be able to measure what's called minimal residual disease, which is called MRD, minimal residual disease, myeloma at a very low level. And this allows you to track it there. And then it needs to be a very precise and a reliable test where you're willing to say that we can make a treatment decision based on that. You need to be secure that you can say we are willing to stop the treatment. As Jean-Luc was saying, after 1 year of maintenance, if it's MRD negative, no minimal residual disease, you need to have some degree of confidence in your test that you could stop treatment. On the flip side, if you have evidence of minimal residual disease, part of this project is to understand why is there residual disease? Why is this disease resistant to the therapy? And have some decision to use some other therapy or enhanced therapy to get rid of the minimal residual disease. So there are 2 parts to this. Stop if you're confident that there's no disease left. Change the treatment if there is some MRD left. So we've been working on this basically for 2 years now. So where are we and what are the next steps within this project? And so to achieve a cure or to attempt to achieve a cure, the key thing is to start early. And Jean-Luc has emphasized what has been accomplished treating patients who have myeloma, as we have recognized it up to now. Myeloma with CRAB criteria, and he showed you the steady improvement with the introduction of high-dose melphalan and stem cell rescue, the improvement with the novel therapies. So a way to do better than that is to start earlier. And if you start earlier, there are 2 key aspects of that. Number 1, there's less myeloma. The second thing is that it's not such ugly myeloma. There are fewer of those translocations and mutations. There is a lesser likelihood of having that 17p or that 414. Unfortunately, what we do know that even if you go all the way back to MGUS, that about half of the patients with MGUS do have some chromosome changes, particularly with chromosome 13, for example. So we know that going early is better, although right now at least, it doesn't take us back to where all the patients might have normal chromosomes. But certainly more of them will have normal chromosomes the earlier that you go, and they'll certainly have less disease. Then you need to be able to figure out what you're doing, and then you need to have clinical trials to see if changing your pattern of treatment is going to improve the outcome. So we were very pleased when Vincent Rajkumar, as part of the Black Swan program and as part of the IMWG, put forward this new diagnostic criteria paper, which was published in November last year. And this is the basis for the slim crab criteria, where we can now classify myeloma at an earlier stage. And it also allows us to separate out patients with smoldering myeloma that are even in the earlier category. And so focusing on these clearer criteria allows us to assess the type of patient that we're offering treatment to with a chance to have a better outcome. And so we've already talked about this, the crab criteria and the slim crab myeloma defining events. This has been a key step forward in our ability to treat myeloma aggressively early with an intent to do a better job. And I'll just skip over that. So the important thing about classifying complete remission is that up to now, it hasn't been as good as we need it to be. And so there are three different ways in which we can look at a complete remission. So the first one is to look at the amount of myeloma in the bone marrow. So the traditional way to have a complete remission right now is to have less than 5% plasma cells in the bone marrow and identify them as being monoclonal or myeloma or not. But this is actually a very, very difficult test, because just looking under the microscope, it's very, very hard to see, is there an occasional plasma cell there or not. And so looking at the bone marrow, we need to go beyond what we call immunochemistry here to use a molecular technique, PCR, which we've used for a number of years, or what is called next generation. Now, this is kind of the modern lingo, next generation. It means right now is what it means, actually. To use either sequencing or a flow method to assess, is there any myeloma left in the bone marrow? So sequencing is that you take the bone marrow and study it at the molecular level. Flow means that you take the bone marrow and you run it through a flow machine, which is able to detect the myeloma cells and to count them and see how many that there might be. The other way to assess if there's residual disease and how good the remission is to look at the production of things that are coming from the myeloma. As we've talked about during the morning, the myeloma cells, they produce the spike. It's possible to measure the spike using much, much more sophisticated and sensitive methods. That's not routinely possible right now, but it could be accomplished. Another thing is to use the heavy light test, and you heard about that yesterday. In a quantitative way, it is possible to use the heavy light to measure certainly IgA, but also IgG down to very low levels, similar to or maybe even beyond the level of immunofixation. You can also use free light as a measure of how low the disease is. And then you can use imaging to see, is there any myeloma anywhere? And so in terms of imaging, the test that we are looking at is PET-CT to see, is there any myeloma left? And one of the problems that we have with that right now is that that is not standardized. a PET scan, and I showed you a picture of PET scans first thing this morning, is that you're looking at the spots. You know, the nuclear medicine folks are looking to see, is there a spot of myeloma? Now, that's not so strongly scientific. And so they use something which is called a standardized uptake value, SUV, to see is there strong uptake there or not. And so we need to have a cutoff to say, is the PET scan positive or negative? And this has not been established internationally to say that we have a clear SUV cutoff for a positive scan or a negative scan. And we actually have the team from Italy in Bologna working on this. Dr. Cavo and Dr. Elena Zamagni are looking at this to try to come up with a standardized way to have a positive or a negative PET scan to help us with number 3 here. I just want you to be aware, as far as the sequencing goes, what we hear about here in California is the Sequenta method, because Sequenta is a company that's based in South San Francisco, and they do have a method for sequencing. But there are other companies, and they're also homemade. You can do it in your garage if you want to, really. You need a few bits of equipment in your garage, but you can do it. And so this is not a standardized methodology right now. And as I'll show you, one of the problems with sequencing is that you can't get it to work in every patient. About 12 to 15% of the time, you can't get this technology to work. And the second thing is that, is it more sensitive than using this flow method, which is what we've been studying? And so one of the first parts of this project was to review grants and proposals from different groups. Okay. And the group in Spain, under the direction of Jesus San Miguel in Salamanca, he's more recently moved to Pamplona, where they have the running of the bulls. I think his hospital's not right down by the bull area. But they have a very sensitive method for measuring with the flow method. And so we basically established a research grant program with them to work harder to come up with a more sensitive method for running the cells through the flow machine so that we could pick up, this means 1 in a million. So if you would be able to pick up if there's 1 in a million myeloma cells there. And this is much better than having a pathologist come back from the coffee break and look down the microscope to see if he can see any myeloma cells there. This is a very sensitive method, and it has 2 parts to it. One is that they used a different cocktail of antibodies to detect what's on the surface of the myeloma, and so they came up with a new cocktail to detect the myeloma. And they also came up with several enhancements to detect the myeloma. So up to now, the way that myeloma has been detected is to compare it with the normal marrow, so that you run the cells through, and then you ask the question, is this myeloma or is it normal marrow? So you're comparing myeloma with the normal marrow. What they have done is that they have established a computer database, and they've said, this is what myeloma is. And then they run the cells through, and then they say, is this myeloma or not? So they're comparing the cells with myeloma or not versus normal or not. And this has turned out, using a computer file with thousands of cases of myeloma now, this is a much more efficient way to identify, do you have myeloma or not? They have been also looking at different machines with different numbers of colors. It's amazing. You can use 8 different colors on the same cell. And so it's like all the colors of the rainbow to detect and sort out the patterns. And the best way to do that is actually with what's called multidimensional software analysis. And so part of this team is a high-level computer team. Although, when we visited Salamanca, we asked to see the guy who was working on the computer program. And they said, oh, yeah, he's actually in here. He's actually, if you go over towards that back window there and then in the little corner. So there was a little guy, he had a desk about the size of this, and he was working on the software program. But he'd been working on it for a couple of years. And he came up with a computer program that allows this to be analyzed in 12 minutes now. So this is what is called real time. So you can run the cells through and you can get an answer, a very precise answer. And so this has been a very successful part of this project. And so we have a protocol which includes eight colors. And then these are the antibodies that we use. An important thing for you to be aware of is that these things which are on the surface of the myeloma can be the basis for diagnosing the myeloma, but also treatment. So if you look at these numbers here, I'll just mention, so this is CD38. So we have anti-CD38 against, so you identify the myeloma that is positive for that. But you also have CD138, which is another one, CD56, and then this one is CD19. All of these are the basis of treatments for myeloma. So you can identify the myeloma, and then you can also identify the density or the amount of those antibodies in thinking about whether it would be a good target to treat or not. And there's a 2-tube method here, and then this is the 10-color method. So they're studying all of those details. Right now, the idea is that if this is going to be an efficient way to look at myeloma, then people around the world need to be able to use this test to figure out how well the treatment is working. So there needs to be a method that can be widely applied. And so fortunately, this flow cytometry, this flow method, is available at all the different hospitals, mostly. All large centers have flow cytometers. They use them evaluating a number of different diseases. And so right now, in the US, these are the teams that are using this 8-color gold standard method. And then it's also been adopted very quickly around the world. So we're very excited about this because this means that we can move to the next stage now and evaluate all kinds of different treatment protocols to see if we're getting an MRD negative status. So the question is, if you compare this next generation flow, which is convenient, it's widely available, it costs about $100, $150. The sequencing costs more like $1,000, and most people would be sending it off somewhere, so you would not get the result right away. The flow method, you have what's called real time, where you could run it down the hall and you would get the results that same day. If you look at what we have so far, and we're looking at both, we've been evaluating the sequencing and we've been evaluating the flow. The NGS, the sequencing, we were only able to get it to work at the very low levels. The Spanish team, they've studied, it's not on this slide, but they've studied 275 bone marrows so far. But looking at the very, very low levels where there's maybe only 1 in a million cells left, comparing whether the sequencing is better than the flow, they were able to get the sequencing to work in 14 out of 16, which is 88%. So 12% they were not able to get it to work. But from our standpoint, what was more important is that they look here, this is the NGF, the flow was positive, and then it was negative. Two patients out of the 14, which is 14%, were positive with the flow and negative with the NGS. So from our standpoint, it means that the flow is at least equally sensitive. And we can get it to work in every case, whereas here that you can't. So we're very pleased that we have a method that's good, we can apply it all the time, and we're continuing to compare it against the sequencing. So You have to indulge me a little bit. I just like to show you the swans everywhere. See? So we've got swans in the US, we've got swans in Europe, and we've got swans in Asia. We even have a swan down here in Australia. So Dr. Andrew Spencer in Melbourne, Australia, he has integrated the MRD testing into a trial with carfilzomib, thalidomide dex in Australia. Sorry? Okay. The question that was illustrated by Jean-Luc Harrisseau was complete remission. How good is the complete remission, and what is the value of transplant or consolidation for patients who are in complete remission? And this shows you here, when you use that MRD test and you look at patients who are in complete remission. So if they have a complete remission with induction or with transplant, would there be any value to get rid of this noise? Would there be any value in going deeper? And this tells you right here that there are positive, about half of the patients are MRD negative, but 51%, if you go deeper, you will find myeloma. And so if you put this in the form of an iceberg, what that means is that this is what we're seeing right now with complete remission. But if you go deeper to this level, all the way down to 1 in a million, you will pick up lower levels of disease. But you can also see that most of the myeloma is kind of just right below the surface. So we're actually pretty close to eliminating most of this iceberg. You can see that there's a little bit down at the bottom here, but actually most of the disease is in this upper area here. So this gives you some encouragement about how much deeper do you need to go to get rid of what's left. The percentages, 22% just underneath the surface, another 20%, 8%, and just a tiny amount right down at the tip there. We've been trying to get the colors right so we can see all of these, so it's not perfect yet. Sorry about that. If you look at an individual patient, and again, this is what Jean-Luc was talking about, you can see the impact of, this is what happens at the MRD level when you take 3 to 4 months of like CyBOR-D or VRD, then you can have some MRD left. Then you do your high-dose melphalan and stem cell, you get it down to here. Then you do your consolidation, and then you get it down to here. So you can actually document how much added benefit, how much farther down the iceberg are you getting with each of these different steps. So we now have in place the ability to assess what we're doing with these different therapies. And so different trials are cropping up globally, actually. People have realized that they can now start looking at myeloma in different ways. And we are supporting already several trials looking at these different aspects, which I'm showing you here. So the first question is, if the MRD is negative, are we confident that we could stop and just monitor? Or, like the French right now, should we maybe maintain for maybe a year or so and then stop, monitoring the MRD alone? In the IFM trial, about 14% of the patients improved further during that 1 year of maintenance. And so then we would see, do we need to continue longer, or we can safely stop there. But a key part of this Black Swan project now is to study patients who are positive and have residual disease. And for them, there is a need to understand the nature of the cells which are resistant to the current therapy. And so several groups who are part of this Black Swan team are looking at the myeloma in this residual disease setting. So the first thing that's come up in the discussion is that some patients can do just fine, even although they have some myeloma left. And this appears to be related to the fact that they can have what's called an MGUS-like signature. In other words, they've kind of reverted back to the MGUS, which can hold steady, even though it's there, but it's not doing anything. And so you can identify that using the flow machine. You can use the flow machine, and about 10% of the patients show that. You can also do it using molecular methods, using this what's called GEP, where you can have the pattern of the genes that will tell you the cells that are left are green, which is this MGUS, or the cells that are left are active myeloma, which is these red ones over here. So you can tell that maybe it's MGUS and maybe you could stop, or it's red and maybe you need to find out more about that. This is, we can skip this really. This is just to show that for those patients that have the MGUS signature, even although they don't have a complete remission, the survival is good. They don't need to get into a complete remission. Of the patients who have residual disease and it has the pattern of myeloma, several groups have started to look at what is the pattern related to the treatment that they have had. And so the question is, if they have had Velcade and there is myeloma left, do they have a pattern of where the cells which are left are resistant to Velcade? And see here, this is the pattern at the start of the treatment, and this is the pattern at the MRD point. And you can see that they have more red over here. And so the question is, what is that red? And so in the case of Velcade, what has been found here is, and this was presented by Dr. Bruno Paiva from Spain at ASH, and has been published actually now, that this is a proteasome subunit. So basically, the cells can kind of sneak around the Velcade therapy and become resistant to it. So obviously, this is very important to come out with what treatment should be recommended. You can also look at the pattern of what is on the surface of the myeloma. What we know right now is that when the myeloma is when you're starting on treatment for myeloma, you have 5 or 6 subclones. So it's not just one collection of myeloma. There are 5 or 6 variations on the myeloma. And so at the MRD point, you might have 1 or 2 clones left, and those clones are not the same as they were at the beginning. And this is looking at some of the surface markers, and this is a system which is called the checkpoint area. Are the cells being controlled by the immune system or not? What is the pattern of what's called PD-L1, PD axis, which is the control mechanism between the T lymphocytes and the myeloma? And what has been found here is that, I won't go into all the details, but basically there is an increase in this regulatory mechanism in these resistant cells. So this could be a target for treatment for the resistant subclones. And so the idea is to look at the immune level, and as I'll show you in a second, at the molecular level, to see for the residual cells, what would be the targets for therapy. And for us and for you, it is incredibly exciting. Look at all the targets, including the sign at the back, that are available to treat the residual myeloma. In this box right here, you have the green dots, and those are the surface patterns where we already have treatment. And so here we have daratumumab and the SAR compound against CD38. These are areas where we already have drugs that work. Over here, there are treatments that can work frequently in combination. And then the CAR T cells. We'll talk about these therapies later in the day. As far as the molecular, we have a number of targets, but our ability to treat that is currently much less. But we're looking at those patterns. In addition, Jean-Luc mentioned that we have the response criteria. Using this, we're switching the response criteria. Right now, we go from complete remission to stringent complete remission. Now, we're moving over to MRD negative. And what this means is that we're actually going to get rid of stringent complete remission and use MRD negative as the new target for therapy. And we're using definitions for molecular, flow, and the PET scanning, which needs some work, but we're aiming for that. And so this is exciting. We have upcoming trials where we're actually looking at a blood test. So instead of sampling the bone marrow, you'll be glad to know that we're looking at several different types of blood tests to assess this. I know, you'll be disappointed. No more bone marrow. I'm sorry. We can take it in the blood. And so we have some exciting information on that. And we're using that as a basis for decision-making in the smoldering area. So we have data, for example, that using a blood test, a single blood test, we could identify the patients with smoldering myeloma that might be active and are candidates for therapy. And then over here, I've already mentioned, there are 3 possibilities as the area of MRD. It can be negative, it could be MGUS, or it could be resistant. And obviously that would be the basis for different treatment options. There are 2 trials. This trial has already started in Spain, and this is called the CAESAR trial. It's a curative strategy, which is Spanish for strategy, smoldering, and then alto, which is the Spanish for high. So it's a curative strategy for high-risk smoldering. And this is using carfilzomib, Revlimid, and Dex. It's using stem cell transplant for smoldering myeloma, and then with some maintenance, consolidation and maintenance here. So a very aggressive approach. There's also a US study, which will hopefully start later this year, very similar, where we are in addition adding in daratumumab in the induction and the consolidation. And the idea is to really eradicate disease in patients with high-risk smoldering. The other point, just to end with, is that we're looking at getting rid of the myeloma. What we've also learned, though, is that there is a unique immune signature. And so as you get rid of the myeloma, the normal immune recovery shows a particular pattern. And that there are increased numbers of Treg cells, regulatory T cells, of a type called Treg number 17. So there's a pattern that occurs in patients who have had a low level of myeloma, have stayed in complete remission for a long time, and then have reconstitution of their immune system. So that's going to be part of the equation. Myeloma down, normal immune system up. So we have a very ambitious plan. We're very excited that we're making progress. We're down to some key steps here. We're at this stage here. We're very keen to come up with a blood test. We want to understand MRD negative. We want to have therapies to get rid of MRD positive and then move forward from there. So hopefully this gives you a good idea of what this is all about and how excited we are about the progress that we're making. And so as compared to first thing this morning, I've moved the myeloma over here to a rock where he's got a spotlight on it. The Swan. The Swan was in the shade, and we've now moved him into the light. Thank you.
Could you go over it all one more time?
Mm-hmm. All right.
Question? Go for it.
I have a question here.
All right.
With horror that Cedars-Sinai was not on the list, when will we have the NGF 8-color gold standard here in Southern California?
The first place that will probably have it up and running is City of Hope. And so we're working with them. So I think that right now that'll be the place. And I'm hopeful. The machinations at Cedars are such that I want it to happen, and maybe we can get it to happen. Have they set it up with the new method yet?
Here, hold on, Bob. Suzanne,
We'll get you a mic.
Because I did talk to them a few months ago and told them about the need for this assay, and so they've set it up to my knowledge.
So yeah, we will definitely try to help them to get it up and running. It's one of those things where there's a difference between the doctor in the clinic and then the doctor in the lab. So we talked to Bob and he says, great, we'll set it up. And then we call the lab and then they don't call us back. Okay.
Okay, question over here.
So you mentioned that you could have either MGUS or smoldering, then the disease progresses, but then after treatment, you return to sort of back to an MGUS state. And then in Dr. McHale's presentation, he talked about if MGUS, you're not really doing anything. So what are you when you're sort of this back to MGUS?
So what was that last? What are we?
When you've had treatment and you return to what you call an MGUS-like state,
Right.
Are you treating that as if it's MGUS, or are you treating that as if it's an active disease?
So the importance of identifying that is that it's a type of patient where we would feel more comfortable to stop therapy and watch. And on the opposite side, where it's not a good idea to give more toxic therapy to get rid of it because probably it's going to be holding steady. But I mean, is Dr. McHale still here? Yeah, so you want to comment on that subset where if you had an MGUS signature, maybe you would stop versus treating?
Sure, thank you. So it can be viewed in different ways, but what we think is probably happening, we see a bit more of it in the hyperdiploid states, is it could be that someone has more than one clone, as Brian described, and one of them is kind of an MGUS-like clone, very, very slow growing and probably never means anything. And then there's some additional ones that grow that are true myeloma. So you treat the myeloma ones disappear, at least temporarily, and that little MGUS one is left. Remember I commented in my presentation we have some patients, ironically, that may live the longest of myeloma and they're never in a complete remission because there's always this little schmutz of MGUS clone that hasn't left. And so in that situation, those are the people that we don't really want to treat because that's like treating MGUS. You're really treating the dust that's in the corner that's not affecting anybody, and it's only going to introduce potential toxicity to the patient, not help them. This all theoretically sounds delicious, but it's hard to know when you're looking at a patient to know, is this your MGUS clone that's left or the other clone? With some of these techniques, we hope to be able to identify that a little bit better. But it's a complicated disease. That's not the way it is with everybody. There's some people where it seems to be just one clone. There's some people where it's a rapid-going clone, et cetera. So it's not that simple, but we do think that with this kind of testing, if we end up having someone that has that little MGUS clone that's left, we probably won't treat them because it's not likely going to change their outcome.
Right. But thus far, what we're seeing is that typically you might go from 5 or 6 clones, as Joe just said, to maybe 1 or 2 clones. And so you might have a couple of clones left.
Doctor?
Hi. Until recently, my impression about minimum residual disease testing has been that the main use of it is as a new endpoint for clinical trials,
Yes.
so that we have a way to measure the disease to a much more sensitive level,
Right.
and possibly be able to tell whether it's cured. But from a remark Dr. McHale made earlier this morning, I want to ask, has it gotten to the point where, at least at some institutions and maybe for a certain subset of patients, it's used outside clinical trials to help determine the course of treatment for those patients? Or is it still just
Right.
in clinical trials?
Okay, so maybe we can both comment on that. So I didn't show one aspect of the Black Swan, which is to start to use the MRD as a primary endpoint, as you're saying. So if you have 2 treatments, and one of the treatments gives you 40% MRD negative, and then another treatment gives you 20% MRD negative, then the one treatment would be better than another, okay? And so within trials right now, for example, in the ECOG trial, in the Endeavor trial, Dr. Shaji Kumar is doing MRD in Kyprolis dex versus Velcade dex. And in that study, it will be what's called a secondary endpoint, where we'll see what is the MRD. If the FDA ends up being convinced that this is a reliable endpoint, that the difference translates into a longer remission of at least 6 months or survival of at least a year, then this could move into a position as a true primary surrogate endpoint. And we're definitely aiming for that, okay?
Yeah, Brian, I would just comment that, you know, I hope I didn't say too prematurely this morning, but I think it's safe to say we're not at a stage yet where MRD testing is really changing what we do every day in the clinic.
Right.
But there may be a small percentage of people. We've heard some of the discussion today about maintenance therapy, to maintain, not to maintain. Should everybody go on maintenance therapy? Should someone who has low-risk disease, who's in a complete remission, go on maintenance therapy? We have a discussion with our patients, and I suspect that right now there'll be a small subset of them that are in complete remission after a transplant, who are maybe leaning towards, maybe I'll just take nada for a while. Maybe I'll just wait and watch. If I told them in addition, oh, and by the way, your complete remission is MRD negative, that might even further, no pun intended, consolidate their decision, right?
Right.
It might further enhance their decision. Whereas if there was still disease positivity, because some places are taking the approach that in general we're using maintenance therapy, but maybe in the exception of a few people who are really in a deep response, who have low-risk disease, maybe we can just wait and watch. So that's maybe the one place right now, because
Right.
some of the Spanish studies did show, looking at that at the day 100 visit, as it were, not just your cytogenetics, not just other ISS-like factors, but your MRD status could predict prognosis down the line. So I don't want to make it sound like we're using it routinely every day, but I think in that small subset, it's just one other small piece of information that might influence us one way or the other. But I don't want people to feel like, oh no, I'm not getting this testing and therefore something big is missing in my clinical care, because it's really not the standard of care, and it won't be until, as you described very well, Brian, it's well documented in larger trials, and is FDA recognized.
So the whole Black Swan project, as far as the clinic, is in the form of trials. We need to understand what negative means. We need to understand what positive means. And so we are absolutely not recommending it in clinical practice right now. And we're actually quite anxious about the fact that as we are standardizing the method and it becomes feasible to do it, that decisions will end up being made. The first thing is to standardize the method, so that, and this has been a big problem up to now, but we've basically described the recipe right here, and if this becomes standardized, this could be a basis for decision making. But right now, I think it would be a basis for prognostic assessment mostly, where obviously if you're MRD negative, we would be very pleased, but we're a little hesitant to recommend any changes.
Okay, Suzanne's going to wind it up with one last question.
Right here.
All right.
It's actually a follow-up to what we were just talking about. It sounds like if you have high-risk disease, then in terms of the clinical implications, it really wouldn't have any at this point, because if you would only possibly use it in a low-risk situation, then it sounds like for a high-risk person, there'd be not any clinical value to doing the test at this point. Is that correct?
Right now, yeah, we're not using it in the clinic, partly because the standardized test is not available, and also because we don't have enough trial data to make a decisive recommendation. But a year from now, 2 years from now, I can see where it could be quite widely used, and that's why we're focusing on a method that could be widely used once we understand what it means. And then it could be used in high-risk patients, it could be used in low-risk patients. I could see a lot of use for this. The other thing is that truly, if we can get it to be useful as a blood test, this is going to be much more valuable and much more broadly applicable. And so you can see that this whole area of research is moving quickly. This is just in 2 years. But it's not quite into the clinic, but I think that once it gets into the clinic, it could be very widely used.
A second question is just, did anybody look at genetic risk compared to whether or not there was MRD present? You know, you said there were 50-50.
Yeah, so the several teams, the Spanish and then also the UK team, the MRC team, the group in England have looked extensively at this. And so basically, to achieve MRD and to sustain MRD is much more likely in patients with good risk disease. So in terms of our ability to cure myeloma, our ability would be to start early, and then our best chance would be in patients with good risk disease. But our ability to find out what would be the best drugs to get rid of every last bit of myeloma, that will probably come from studying high-risk disease. And those protocols in high-risk disease with new drugs and new combinations will be incredibly helpful to use earlier.